All right, welcome to our short lecture about pain in the older adults. We will just be discussing some basic information and you will review quite a bit more in your pain class that you will have in your spring of your DBT 5 year. So when we're discussing the pain in the older adult, we have to consider that 25 to 45% of community dwelling older adults have chronic pain, and 45 to 85% of nursing home residents also report pain that's left untreated. So it is a very common symptom, but we have to recognize the fact that although it's very common, it's not a normal part of aging. Increased pain can result in decreased socialization, impaired mobility, and ultimately increased healthcare utilization and cost overall. There's a lot of other consequences of increased pain that can include depression, anxiety. It could be a risk for falls due to decreased mobility, malnutrition, reduced cognition, impaired sleep. All of these components could result from an increase in pain reports from an older adult. Now, how do we assess it? Well, it's very simple. Self-report remains the gold standard in assessing by utilizing either the visual analog scale or a FACES scale. Studies have shown that 86% of nursing home residents can complete at least one of these pain scales with high reliability and high validity. Now, the visual analog scale doesn't replace a physical exam or medical history interview, right? So it's really important that we still always assess the visual analog scale or the FACES scale, depending on which one would be easiest for individuals to utilize. Proper use of conservative intervention for pain control can lessen the need for medications and may allow for postponement of elective surgeries. Now, sadly, conservative non-pharmacological interventions are not often utilized in management of some diagnoses that are associated with pain. So oftentimes, especially in the older population, doctors will quickly revert to utilizing medications. Now, the great thing is that this practice is ending very often, and all of the research that's out there shows that as physical therapists, we can make a significant decrease and a significant impact in the resolvement of pain in our older adults. Okay, so this is our only quiz for this lecture, and we're going to talk about assistive devices as interventions for pain. So which of the following statements is false? Right. So the fact is, we really do have to make sure that if we are utilizing any sort of devices for interventions, especially when it comes to pain, we have to fit the devices, regardless of the time frame that the person is going to be utilizing the device. Now, as therapists, there are thousands of devices that we can utilize, but we have to remember that any assistive device is going to limit mechanical forces that stimulate pain at the site of pathology, trauma, and inflammation. So things like canes and walkers will decrease the mechanical force in the lower extremity, but it will increase the mechanical force on the upper extremities. Utilizing different footwear, orthotics, orthoses can help with absorbing impact in the lower extremities. There are spinal braces that can help decrease some of the forces in the spine. So the Jewett brace you'll see at the bottom right-hand corner, the Cash brace, and the TLSO compression fracture braces, all of these components can help decrease some of those forces in the spine. Now we need to consider some of the adverse side effects of utilizing these external devices. Things like skin breakdown. If somebody's wearing an orthotic device, you have to pay special attention to the skin. You might have to consider some of the psychological dependency that starts occurring. So if somebody's wearing a CASH brace or a spinal med brace for spinal decompression, they might feel like they can't ever take that off. And that's not the point, because we want to make sure that we keep the individual's muscles strong, right? So another effect is that weakening of the muscles. So we want to try and strengthen the muscles as much as possible and utilizes the orthoses to try and help improve overall function. Proper evaluation, selection, and fit, even with short-term use, is warranted, and it's important to prevent any form of further complication for our clients. Now, other considerations, we talk about modalities. There are actually very limited studies on older adults when it comes to modalities, but let's talk about a few other things. Massage. You can utilize massage or manual therapy techniques with our older adults to help with some of the pain management. Now, it might require some special positioning due to medical conditions and or deformities, right? So here's an older adult in your picture, an individual that has an increased thoracic kyphosis. You have to consider, can I get this person laying down prone? The answer is yes. Can I get this person laying down supine and side lying? The answer is yes. But I'm going to have to consider, all right, what are the special position and things that I might need to make sure that this person is comfortable and is safe in this particular position while I'm addressing some of the postural components or some of the manual therapy components, right? If somebody has COPD, for example, they might have a hard time laying flat on their back, so you might have to elevate their head, increase the number of pillows for support. And again, you have to consider what is your ultimate goal and outcome for the massage or the manual therapy techniques that you're going to be utilizing. E-stim is another intervention that you can utilize to help alleviate some of the pain. So there is an increased incidence of dry skin in the older adults, and that can result in dermatitis at the electrode site. So that could result in some increased redness of the skin. That dry skin can also increase resistance to the flow and require a higher intensity of stimulation. So you want to utilize an electrode gel or water to decrease resistance where it's appropriate. You might want to look at alternate electrode placements. You want to hold down underlying skin when removing their electrodes because the skin might be a little bit thinner. So you have to consider the removal of the electrodes and removing that nice and slow and holding down that skin to avoid any sort of skin breakage. And utilization of electrical stimulation is contraindicated with any form of pacemaker or internal stimulating devices that the patient might have. Now, when it comes to utilization of thermal agents, we really have to be careful. Heating pads, ultrasounds, things like that. Individuals have an increased risk of injury because of due to a lot of things. Now, this is specifically a research study that looks at osteoarthritis, but it's applicable to all diagnoses and to any older adults. Older adults have a decreased hypothalamic thermoregulatory system. Right, so they can't respond to that increase in heat. That decreased autonomic and vasomotor responses are decreased. Impaired circulatory systems, decreased perception of thermal gradients. So they're not going to feel that what you're applying is too hot or too cold. So you have to be very careful. And medications that the individuals are taking could also impair that thermoregulatory control. So if you are utilizing thermal agents for our older adults, please keep in mind that you really need to monitor them very closely and very often. Again, you can totally utilize heat to help with some of the pain management, but you want to use the heat at lower temperatures for the heating agents and higher temperatures for the cooling agents. So you want to not have super, super cold or super, super hot. Well, you want that these changes produce slower rates of temperature change. I get that, but you'll also want to shorten the time for superficial heating agents. So you'll have to balance out the pros and cons of utilizing some of these thermal agents with our older adults. Now, exercise, right? Here's a checkpoint for you. Exercise is the category that has the most studies as it has a direct effect on pain. right? You have increased input on joint mechanical receptors through passive and active exercise. You have the indirect effects of exercise that relate to increased blood flow that disperses chemical sensitizing agents. That's going to lead to decreased edema, increased range of motion, improved flexibility, increased relaxation, and overall decreased anxiety. So exercise, the category that has the most studies. Checkpoint for you right there. Now, it's important for us to provide appropriate education for our older adults, and knowing that exercise should not be viewed as a one-time rehab intervention. You can't just exercise one and have improvements, and sometimes you exercise once and pain might increase, but that you need to educate our older adults that ultimately that slight increase in pain is not dangerous or harmful. It's going to be important, and that pain will decrease as you go along, and to really understand the differences and the different types of pain that you could be going through.